Welcome to the deep dive. Today we're getting into something pretty serious, necrotizing fasciitis. You might know it as that flesh-eating infection.
Yeah, it's definitely a scary one, rapidly progressing.
Exactly. Now, we know you listening probably have a solid background in medical science, so we're not going to, rehash basic biology 101.
Hmm.
Our mission today is really to explore an interesting adjunctive therapy, hyperbaric oxygen therapy, HBOT.
Right. Breathing pure oxygen under pressure. Seems simple on the surface.
It does, doesn't it? But how can that seemingly simple thing actually make a difference in such a severe infection? That's what we want to unpack.
We'll be looking at the physiology, how it interacts with this type of infection, and the evidence behind using it based on medical handbooks, research, the usual deep dive stuff.
Let's jump in. So first things first, maybe just a quick refresher on necrotizing fasciitis itself.
Sure. So fundamentally, it's a deep, severe infection. It attacks the fascia, those layers of connective tissue under the skin.
And it's not just superficial, right? It goes deeper.
Exactly. That's a key point. It can actually lead to necrosis, tissue death of the skin above it.
And how does it typically start? Is it always a major injury?
Not necessarily. That's quite interesting. Often it can start from relatively small things, breaks in the skin like cuts, maybe an insect bite, even puncture wounds sometimes.
Huh. And location-wise?
It's seen more often in the lower extremities, the legs, but
Yeah.
honestly, it can pop up pretty much anywhere on the body.
Okay. You hear about other skin infections too. I think I've heard of anaerobic cellulitis. How is this different?
Ah, good question. Yeah, anaerobic cellulitis is another type, but it mainly stays in the subcutaneous tissue. That's the fatty layer just below the skin.
Okay.
The big differences are really the speed and the depth. Anaerobic cellulitis usually develops more slowly, and crucially, it doesn't invade that deeper fascia. Necrotizing fasciitis is faster and goes deeper.
Got it. So speed and depth are the key differentiators there. Now that term flesh-eating bacteria,
Mm.
it sounds like one specific bug. Is that accurate?
It's a bit dramatic, that term. Historically, Streptococcus species were often implicated, which kind of led to that name.
Right.
But the reality, and this is important, is that necrotizing fasciitis is often polymicrobial.
Meaning multiple types of bacteria.
Exactly. You often find a mix, things like Enterobacteriaceae, various anaerobic microbes, maybe alongside strep. It's like a team effort, unfortunately.
Nasty team effort.
Yeah, and that mix contributes to how destructive and fast it can be.
Okay, that makes sense. So multiple culprits. Let's pivot a bit to oxygen. We obviously need it, but what's its specific job in our tissues, especially when fighting an infection like this?
Oxygen is absolutely crucial for our immune response, particularly for neutrophils, a key type of white blood cell.
Our frontline defenders.
Pretty much. When they engulf bacteria, a process called phagocytosis, they use this special enzyme, NADPH-linked oxygen. Think of it like an internal weapon system.
Okay.
This enzyme uses oxygen to create superoxide radicals. These are highly reactive molecules that basically destroy the bacteria inside a little compartment called a phagosome.
And the amount of oxygen matters here.
Immensely. This whole killing process is very sensitive to the partial pressure of oxygen. The more oxygen available, the more superoxide radicals can be produced, and the more effective the neutrophils are at killing bacteria. It's quite direct.
Okay, more oxygen equals stronger immune firepower. But then you mentioned anaerobic bacteria earlier, the ones that don't like oxygen. How do they fit in?
Right, that's the other side of the coin. Anaerobic bacteria, by definition, struggle to grow or can't grow at all in normal air oxygen levels, around 20%. They have different ways of making energy.
So they prefer low oxygen zones.
Yes, but it's not always a strict no oxygen allowed situation. There's a spectrum. Some are extremely sensitive, but others are what we call aerotolerant or facultative. They might prefer low oxygen, but can survive or even function if some oxygen is present.
Which explains how they can live in our tissues sometimes.
Exactly. Our tissues aren't uniformly oxygenated, especially if there's damage or poor circulation.
Ah, okay, connecting the dots now. So in necrotizing fasciitis, where you have tissue damage and inflammation, that area probably becomes low oxygen, right?
Precisely. That tissue damage, the swelling, the compromised blood flow, it all leads to poorly oxygenated or hypoxic tissue.
And that creates the perfect storm for these anaerobes.
It really does. It becomes an ideal breeding ground for certain pathogens. Think about Clostridium species in gas gangrene, another condition where this happens. They thrive in low oxygen environments. multiply, and release toxins that cause even more tissue damage.
Which probably makes the oxygen situation even worse.
Exactly. It's a devastating cycle. Infection causes tissue damage, which lowers oxygen, which allows anaerobic bacteria to thrive and cause more damage, and so on.
Okay, this really sets the stage for understanding why you'd even consider something like hyperbaric oxygen therapy. So walk us through it. How does HBOT actually work on a basic level?
The core idea is straightforward. The patient goes inside a specially designed chamber, and they breathe 100% pure oxygen. Critically, the pressure inside that chamber is increased.
How much pressure are we talking about?
For necrotizing fasciitis, typically it's raised to 2.0 to 2.5 atmospheres absolute, or ATA. So that's about 2 to 2.5 times the normal air pressure you experience at sea level.
Right. And breathing pure oxygen at that pressure.
Right.
What does that do physiologically?
It does a couple of really key things. First, it dramatically increases the partial pressure of oxygen, the PO2, within the tissues themselves.
Even in those damaged low oxygen areas?
Yes, that's the goal. You might see tissue PO2 jump from, say, a very low 15 millimeters of mercury in a compromised area up towards 100 millimLg or even higher during the treatment.
Wow, that's a big jump.
It is. The second major effect is that it forces much more oxygen to dissolve directly into the blood plasma, the liquid part of the blood.
So not just the oxygen carried by red blood cells.
Exactly. Normally, most oxygen is bound to hemoglobin in red cells. With HBOT, the amount of oxygen physically dissolved in the plasma can increase massively, maybe 10 to 20 times normal levels.
And why is that dissolved oxygen so important?
Because plasma can seep into areas where blood flow might be sluggish, or where capillaries are damaged, places red blood cells might struggle to reach effectively. This dissolved oxygen can diffuse further into the tissues, reaching those hypoxic pockets where the bacteria are hiding.
Okay, so we're essentially flooding the entire system, including the damaged areas, with much higher levels of oxygen. How does that specifically help fight necrotizing fasciitis?
It attacks the problem on multiple fronts. First, directly against the anaerobic bacteria. High oxygen levels are toxic to many of them.
Makes sense given they don't like oxygen.
Right. In vitro studies, lab studies, have shown that these high oxygen pressures can directly inhibit the growth and, importantly, the toxin production of bacteria like Clostridium perfringens.
Stops them multiplying and stops them making those damaging toxins.
Exactly. Second, remember our discussion about neutrophils.
Yeah, the immune cells needing oxygen for their weapons.
HBOT supercharges them by providing way more oxygen right where it's needed inside those phagosomes. It significantly enhances their ability to kill the bacteria they've engulfed. Their oxidative peeling capacity goes way up.
So it hinders the bad guys directly and boosts our own defenses. That's quite powerful.
It is, but there's more too.
Oh. What else does it do?
Well, it seems to help modulate the inflammatory response. In the early stages, it might improve how leukocytes, the white blood cells, function generally. It can potentially reduce neutrophil adherence, basically, stop them from sticking inappropriately, where they might cause more damage, and maybe dampen down the excessive release of damaging reactive oxygen species.
So potentially reducing some of the collateral damage from the immune response itself.
That seems to be part of it. Then, looking a bit longer term, HBOT promotes angiogenesis.
New blood vessel growth.
Yes. This is really crucial for healing. It appears to stimulate factors like VEGF, vascular endothelial growth factor, which drives the formation of new capillaries.
And why is that so important here?
Better blood supply means better delivery of everything needed for repair nutrients, more immune cells, and critically, antibiotics. You need good plumbing to get the drugs to the site of infection.
Right, of course. Makes perfect sense. Anything else?
One more significant effect is reducing edema, the swelling.
How does high-pressure oxygen reduce swelling?
The high oxygen level causes vasoconstriction, a narrowing of blood vessels. But because there's so much oxygen dissolved in the plasma, oxygen delivery to the tissues isn't compromised and might even improve. This vasoconstriction helps reduce fluid leakage out of the capillaries, decreasing the swelling.
And less swelling is good because?
Because swelling itself can compress capillaries, worsening blood flow and oxygen delivery. It contributes to that vicious cycle we talked about, ischemia, hypoxia, edema. Reducing the edema helps break that cycle.
Wow. Okay, so it's quite a multi-pronged attack. Direct bacterial inhibition, boosting immune cells, modulating inflammation, promoting new blood vessels, and reducing swelling.
Pretty much sums it up. It's leveraging physiology to create a much less favorable environment for the infection and a much more favorable one for healing.
Given all that, How is HBOT actually used clinically for necrotizing fasciitis? What's the protocol look like?
The typical recommendation is treatment at 2.0 to 2.5 ATA, breathing 100% oxygen, for about 90 minutes per session,
And how often?
usually twice a day, especially in the initial, more critical phase for mild to moderate cases.
And I think this is crucial, it's not a standalone treatment, is it?
Absolutely not. This cannot be stressed enough. HBOT is adjunctive. It's an add-on. It absolutely does not replace the cornerstones of treatment.
Which are?
Aggressive, and I mean aggressive, early surgical debridement. Removing all that dead, necrotic, infected tissue is paramount. That has to happen, often multiple times.
Okay, surgery first and foremost.
Yes. Plus, prompt and appropriate antibiotics, ideally targeted to the specific bacteria identified. And of course, comprehensive supportive care, managing sepsis, fluid balance, all of that.
So HBOT comes in alongside the surgery and the antibiotics to give the patient the best possible chance.
That's the idea. It supports those primary treatments.
And does the treatment schedule change as the patient improves?
Yes. As the patient stabilizes, as the infection comes under control, the frequency might be reduced, perhaps to once daily. This might continue for a period to really consolidate the gains and help prevent recurrence before stopping HBOT altogether.
Timing seems critical here too, getting started early.
Very much so. With necrotizing fasciitis spreading so rapidly, early intervention with all modalities, including potentially HBOT if appropriate and available, is key to limiting the extent of tissue loss and improving outcomes.
It certainly sounds like a valuable tool in the arsenal against this horrible infection. Are there downsides or things to watch out for? Risks?
Like any medical procedure, yes, there are considerations. HBOT has contraindication situations where it shouldn't be used or needs extreme caution.
Such as?
The classic absolute contraindication is an untreated pneumothorax, a collapsed lung. Putting someone with that under pressure is dangerous. Also, conditions like acute severe bronchospasm need careful assessment.
So careful patient selection is vital.
Absolutely. A thorough evaluation is needed beforehand, and then there's the facility itself.
What about the facility?
You need properly designed hyperbaric chambers and trained staff, especially for these patients who are often critically ill and might need intensive monitoring and support during the treatment.
Are there different types of chambers?
Yes, broadly speaking, monoplace chambers treat one person at a time, while multiplace chambers are larger rooms that can hold several patients, and often staff members too, allowing for more hands-on care inside. Each has pros and cons regarding monitoring and intervention capabilities.
And safety must be a huge concern in an oxygen-rich, pressurized environment.
Immense. Fire safety protocols are incredibly stringent and absolutely non-negotiable in hyperbaric medicine.
Understood. Okay, so let's try and wrap this up. If we were to summarize the main point of our deep dive today on HBOT and necrotizing fasciitis, what's the key takeaway for listeners?
I think the core message is that HBOT offers real physiological advantages when fighting necrotizing fasciitis. It hits the infection by directly impacting anaerobic bacteria and by significantly boosting the body's own immune system in those dangerously low oxygen tissues.
But always as part of a team effort.
Always. It's a powerful support player working alongside the essential stars, surgery and antibiotics. It helps create conditions where those primary therapies can be more effective.
It really is fascinating, isn't it, how just changing the oxygen environment, using pressure, leverages these fundamental biological processes to tackle such a complex and life-threatening disease.
It is. It shows how manipulating basic physiology can have profound therapeutic effects.
Which kind of leaves us with a thought to ponder, doesn't it?
Yeah, it does. If flooding tissues with oxygen can be so beneficial here in this state of severe hypoxia and infection, well, it makes you think, what other conditions involving critical tissue hypoxia might benefit from a similar approach?
Right. Where else is lack of oxygen a major driver of disease or poor healing?
Exactly. And what are the challenges, practical, logistical, economic, in making therapies like HBOT more widely available or applying these principles more broadly?
It's that balance, isn't it, between these high-tech interventions and supporting the body's inherent ability to heal if given the right conditions. Something for you, the listener, to maybe mull over.
Definitely food for thought.
If this has piqued your interest, we absolutely encourage you to look into the sources, maybe explore the wider field of hyperbaric medicine. There's a lot more out there.
For sure.
Thanks for joining us on this deep dive.